Hospitals are striving to reduce the rising rates of pregnancy-related complications and deaths, which are correlated with the rise of C-section rates. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly, Executive Speechwriter with AHA. In this Members in Action podcast featuring maternal and child health efforts, Aisha Syeda, Program Manager at the AHA, speaks with Dr. Nicole Lamborne, the Vice President of Clinical Operations for Women's Services at Virtua Health in New Jersey. Dr. Lamborne will show how Virtua identified gaps in maternal care and invested in laborists, nurses, and evidence-based practices to lower C-section, hypertension, and sepsis rates.
Thank you, Tom, and thank you, Dr. Lamborne, for speaking with me today. To start us off, can you share a little bit about Virtua Health and the community it serves?
Absolutely. Thank you for having me today. Virtua Health is a comprehensive community health system in South Jersey, serving that Southern Jersey community and really the greater Philadelphia region. Our primary patient population comes from three main counties in Southern New Jersey, which is Burlington County, Camden County, and Gloucester County. We do have 5 acute care hospitals, but we have over 250 care centers or care locations that include all of our primary care offices, our urgent care centers, surgery centers, and those types of offices. One of the things I'm proud of at Virtua Health is that women's health is really one of our leading service lines and is one of our strongest service lines. And we do a large number of deliveries, doing somewhere between 8,000 and 9,000 deliveries a year in 3 of our acute care hospitals that do deliveries. So 3 of the 5, we actually have labor and delivery and do deliveries. In addition to that, we have 3 nurseries, 3 neonatal centers. Largest hospital has a level 3 NICU, and our other 2 locations have level 2 special care nurseries.
Thank you, Dr. Lamborne, for providing that background. I understand that Virtua hired laborists and involved nurses in decision-making when it comes to maternal care. Can you share the impetus of that and what's the ultimate goal of involving these healthcare professionals in maternal care?
To be honest and to be transparent, the impetus of starting the laborist program predates me. I was the first laborist they hired to come on board and start the laborist program here in 2010. So the actual impetus is just kind of what I have learned after being brought here and the reasons that I was given to start the program and the focus of the program. You know, the health system was building a new hospital that opened in 2011, and that was our Virtua Voorhees campus. That new hospital was really built to be state of the art and have a new way of approaching healthcare. And the system really saw this as an opportunity for us to evolve our care model and look at opportunities to improve our outcomes and our care delivery. So bringing on the independent laborist model really was designed to provide active management of laboring patients, really ensure that all the patients were being followed according to set protocols that we put in place for quality and outcome standards. We also really wanted to improve the flow on the floor because we are a high volume organization and we wanted to make sure that patients were not stagnating on the floor and that they were actively being managed and providing access for more patients to come in. And really an extra layer of support and attention to the patients to improve their overall patient experience. So really when we talk about triple aim in healthcare, improving outcomes and increasing the patient experience and lowering costs, all of those were components of the laborist program because you can look at the cost of a laborist, but in the end, if you're improving the flow of patients through the system and improving the amount of time, decreasing the amount of time that they're sitting on the floor and laboring, you will ultimately reduce your costs. Plus, obviously, improving the quality and outcomes reduces your liability costs and those kind of things. So really, our focus is around patient safety and the patient experience. We primarily were focused on the C-section rate from the beginning, and that was due to a report that came out based on data of 2010 and 2011 that really showed us to be an underperformer as it related to our C-section rates. And as I said, when I told you about our healthcare system, we really pride ourselves on women's health. And to have that report that was showing that we were really a poor performer in the state as it related to our C-section rates, we really wanted to focus on bringing those down as our primary focus. And the laborist program was the hospital system's part of the program rolled out to really look at that and provide that additional layer of support to not only nursing, but the independent providers to help show them ways to manage labor differently and hopefully, reduce the overall C-section rate. When we started looking at this, our C-section rate was about 38% for first-time moms. So we talk about total C-section rates. We did start to look at primary C-section rates. And then from there, women's health, OB, started to really focus on what's called the NTSV C-section rate, which is our lowest C-section rate of our nulliparous singleton term vertex. So they're considered patients that should have the least chance of having a C-section. And that rate was falling right around 38% for us when the Healthy People 2020 goal was set at 23.9. So we knew we had a lot of opportunity there to improve. For the nursing component, as we looked at this, we also felt it was very important to have a multidisciplinary approach to any quality improvement initiative. And nursing plays a very important role in how our patients are managed and therefore what their overall outcome is. Because especially when we talk about C-section rates, it's not just the end outcome that can be changed. You have to change the whole process from how patients are induced, how they're managed in labor, which will then lead to a different outcome. You can't just look at the outcome and tell people not to do a C-section. You have to look at what led to the C-section in the first place. And nursing plays a vital role in that, and including them in those committees and in those discussions and even in the protocol development was essential for creating that collaborative approach and therefore resulting in better outcomes.
Thank you, Dr. Lamborne, for giving that context. Can you share some of the outcomes you did speak about that it did improve outcomes for your patient population? So do you have any specific results, testimonials, or data that you had collected by doing these interventions and involving different types of healthcare professionals such as laborists and nurses in the plan of care for patients?
Yes. I mentioned the report that came out in 2010, 2011 that really showed us to be a low performer for C-section rates. And the other metrics that were really looked at with that report was episiotomy rate and early term delivery rates. Our episiotomy rate at that time was 11% at one of our hospitals and 14% at the other. The third delivering hospital came on later into our system in 2019, so it wasn't part of that report. But the target nationally was to be 5% or less. So we had a great opportunity there to improve that rate. I can say that we quickly reached that 5% mark over the couple years after starting to look at this and starting some of these initiatives. And then we decided to lower the target because the top percentile, the top quartile in the country was at 2% or less. So we then lowered the target to 2%, and we were able to achieve that in 2015 and have maintained it since. And that definitely was a collaborative effort and just reminding people, increasing awareness on the floor. The next thing that we did move to, as I said, was the C-section rate. And we started out with a 38% C-section rate of our lowest risk patient population. And we are now at 17.9% as of 2020. That was our year-end total for the system. That was a significant decrease, as you can see. And it took a lot of effort and a lot of work, but we're very proud of that. In addition to those two metrics, we moved on to treating hypertension and looking at hemorrhage, which both significantly contribute to maternal morbidity and mortality. For treatment of severe hypertension, our goal was to have the majority of patients who experienced a severe range blood pressure be treated in under 60 minutes. And when we started across the system, our rate ran between 20 and 25% at any one of our hospitals. And we're now, as of the first quarter 2021, we are consistently between 70 and 75% at all three of our delivering hospitals. The hemorrhage risk, we put in a lot of the A1 guidelines to look at hemorrhage risk assessment and completing that at multiple stages of labor, and then quantifying blood loss to really help us know where we stand and get ahead of the curve when patients are actively losing blood. So we are now at 95% completion. One of the other areas we looked at was our hemorrhage protocol and adhering to the A1 guidelines and A1 suggestions. And we are now consistently at 95% completion of our hemorrhage risk assessment, which is completed at many different stages of labor to see where the patient's risk is and modify that risk when possible, as well as quantifying our blood loss so that when patients are actively bleeding, we know more accurately where we're starting from and we can get ahead of that before it's more significant, and it gives us more opportunity to respond to that hemorrhage in a timely fashion. So all of these collectively were different initiatives along the way that we began in this comprehensive and collaborative approach with the laborists and nursing, and really having a multidisciplinary team looking at all of these quality initiatives.
That's wonderful. Can I just ask, what year did this initiative start?
It depends on which one. So in 2010 is when we started looking at our episiotomy rate. In 2012 is when we really started looking at our C-section rate. In 2017 is when we started looking at severe range hypertension. And hemorrhage has been looked at throughout, probably since about 2012 as well, in different ways, and as different information evolved. And the A1 protocol came out, I think, around 2015, if I'm not mistaken. So that's about the timelines on the different ones.
Dr. Lamborne, what are some of the lessons that you've learned and any challenges or pleasant surprises that you've experienced throughout this process?
Personally learned a number of lessons. I realized that you really can never underestimate the importance of education and awareness and really engagement of all the members of the team, because as I said before, how important it was to include nursing and really have a comprehensive collaborative approach. It's so key. Everybody in the system really has to be on the same page, receiving the same information and the same level of engagement for it to ultimately be successful. Getting buy-in from the different members can be challenging depending on where their mindset is coming from. We, as a system, have a large number of completely private practice physicians not employed by the system, very different. Some of them are collectively under a management umbrella, but not all of them are under one. So you have many different mindsets with competing priorities that make it a challenge for people to accept the changes that you're trying to implement, and really teaching everybody to look at this from a different angle. There were many myths and excuses that we found along the way, especially, physician driven, that took a while to debunk because we really had to provide a lot of education. And physicians generally want to see a lot of data, want to see a lot of studies that support changes to their clinical practice, because obviously they're concerned about their own liability. And if you've done things a certain way as a physician for a number of years, it's very difficult to change and feel comfortable making that change from a safety standpoint. So I think the level of oversight that was really required to continue to press the change, because what we did also see during this really 8-year journey so far on the C-section rate was a lot of waxing and waning, and we would see improvement and then it would start to fall and then we would see some improvement. And it took constant and consistent oversight and messaging and providing that data back to the departments so they could really see where they stood and where they had the opportunity to make change on any given patient. Having the laborists there on the floor every day, and as well as the nursing being involved and being there every day, really helped provide that real-time feedback to the physicians, and encouraging docs to give patients more time in labor if baby was tolerating labor well and the patient was doing well. And that really helped to provide that in the moment change instead of all retrospective reviews. And that's where I found it to be the most valuable. We also then worked on really educating the patient base, because as we started to see improvement with our providers, we were getting pressure from patients, and they had a mentality of this was a more convenient option. It was an easier option to have a C-section. Some people even felt that it was safer. And we really had to do a lot of education around why that's not necessarily the best choice unless it's necessary. We do know that, there's many times that C-sections are medically necessary, but there's a lot of times that they're not. So educating them as to why that's not a good idea, and not a good idea to take any shortcuts as it relates to labor management. We reported this frequently, and that was important too, because if you let it go more than a month, we got to the point at one time that docs really wanted almost weekly feedback on where they were. And that was at the height of trying to make some of these changes. We're now at a monthly feedback and giving data and results on a monthly level, but that frequent data point is really important when you're trying to make significant change like this. And then just monitoring their adherence to all the protocols and giving that feedback as well. So we track everything. It's a lot of data. I'm very thankful for all of my colleagues that collect that data and really help us analyze it, because that, like I said, doctors are very data driven, and that really helped. We actually have physician report cards. We give the report cards out on a quarterly basis, but we give the actual rates and statistics on a monthly basis.
That's great to hear that the hospital is so focused on collecting that data and utilizing that data to eliminate any gaps in care. Were you collecting real data as well to see if hypertension rates or hypertension or hemorrhage rates and C-section rates were more prominent in Black American women?
Initially, no. When we started all of these projects, we are now, and that's, as you talk about next steps, we're really looking at honing down on what our rates are by race and ethnicity and seeing if there's any differences. The hard part with that data sometimes is at any one of our hospitals, depending on the volume of different races, especially, can really swing your rates significantly. So if you have a low volume of Black women at one hospital, it only takes a couple of cases to throw your number off. So the lower volume hospitals already are more difficult. You see a lot more fluctuations in their rates, and that will get even more the more specific you get with that rate. So whenever you get to a very small subset of the population, those numbers can really fluctuate greatly. So we do look at those numbers now. We look at it for our overall maternal morbidity and mortality. A lot of it, we have the help from the state because they collect a state platform of data based on our birth certificate data, and they give that back to us based on our complications by race and ethnicity. And that's really helping us provide that feedback as we're really trying to work with our departments on improving our outcomes for our minority populations and really increasing awareness as it relates to unconscious bias and maybe how we're treating patients and approaching their healthcare can differ based on any biases we may have.
And I know we kind of jumped into the next question, but besides this, are there other next steps that you and your team at Virtua Health plan on undertaking to combat the rise of pregnancy-related complications in your community?
One of the biggest things we're focused on right now was expanding the role of the laborist to include midwife laborists. And at all three of our delivering hospitals, we've now incorporated midwife laborists along with a physician laborist. And this was very intentional part of our program as we incorporated more midwives. When we started all of our initiatives, we had one midwife on staff, and we now have over 25 midwives on staff. And we found that their approach to labor and being more hands-off and supportive of the natural process really helped teach us as physicians to be less interventional and only really intervene when necessary. We also have found with the midwives, they're really trained, and their focus is on spending time with the patient and really having a high touch approach to their care, which has definitely improved patient satisfaction, helps patients really feel heard and cared for. And it's just been a great collaborative process for the midwives to have us there when they do have patients that need an intervention, and us to learn from the midwives in terms of how to sit on our hands a little bit more and intervene a little bit less. And the ultimate of process in our program of integrating more midwifery care has been now to develop our own freestanding midwifery birth and wellness center that we are opening on our Voorhees campus, hopefully over the next couple of weeks. We are waiting on some final inspections, but the birth center will be a completely natural process, and patients will be able to deliver at our freestanding birth center who want that low intervention, natural process. And, this is focused on our low-risk patient population, and it's very focused on being family-centric and, again, supporting that physiologic birth process. So it's something we're very excited, and we really feel that, again, incorporating that midwifery approach to care has helped teach us how to look at labor a little bit differently.
That's very exciting, and I'm looking forward to hearing more about that. I want to say thank you to Dr. Lamborne for sharing all the great work you and your team is doing to improve maternal and birth outcomes for Virtua's community. Your work highlights how evaluating your hospital data and processes and addressing gaps in care can lead to better outcomes for mothers and their families. For more podcasts, education, and additional tools and resources related to improving outcomes for mothers and babies, please visit AHA's Maternal and Child Health webpage. Thank you for listening.